Welcome to our comprehensive guide on blood pharmacology, designed specifically for pharmacy students. In this video, we'll explore the essential drugs and growth factors that play a crucial role in the management of blood disorders. From understanding the basics of hematopoiesis to diving deep into the pharmacology of drugs used for anemia and hemostasis, this journey will equip you with the knowledge needed for both exams and clinical practice. Let's begin by outlining the key learning objectives and setting the stage for a detailed exploration of blood pharmacology. By the end of this chapter, you'll be able to describe the pharmacology of various hematopoietic growth factors, list the types of drugs used to treat deficiency anemias, and discuss the actions, uses, adverse effects, contraindications, precautions, and interactions of drugs used in anemia management. You'll also be able to identify different classes of anticoagulant, antiplatelet, and fibrinolytic drugs, and explain the mechanisms of action, pharmacokinetics, drug-drug interactions, and adverse effects of drugs acting on the hemostatic process. Let's move forward and start with the basics of hematopoietic growth factors. Hematopoietic growth factors are naturally occurring hormones that stimulate the production of mature blood cells, red blood cells, white blood cells, and platelets. These factors are essential for responding to the body's basal needs and increased demands, such as during anemia or infection. For example, erythrocyte production can increase tenfold in response to anemia, while leukocyte and platelet production can also rise dramatically in response to infection or thrombocytopenia. The regulation of these processes is vital for maintaining healthy blood cell levels. The core of blood cell production are hematopoietic stem cells. These rare marrow cells have the unique ability to self-renew and commit to specific lineages, eventually differentiating into over 10 distinct blood cell types. The process begins with pluripotent stem cells, which give rise to multipotent progenitors, and finally to mature blood cells. This entire machinery is housed primarily in the bone marrow and relies on a steady supply of iron, vitamin B12, and folic acid to function optimally. Hematopoietic and lymphopoietic growth factors are glycoproteins produced by marrow cells and peripheral tissues. They are active at very low concentrations and often influence more than one cell lineage. Clinically used hematopoietic growth factors include erythropoietin, epoetin alpha and beta, granulocyte colony-stimulating factor (GCSF), granulocyte macrophage colony-stimulating factor (GM-CSF), and interleukin-11 (IL-11). Thrombopoietin receptor agonists, while not true growth factors, also play a role in platelet production. Erythropoiesis-stimulating agents, or ESAs, are pharmacological substances that stimulate red blood cell production. Erythropoietin, the first human hematopoietic growth factor to be isolated, is primarily produced in the kidneys. Its expression increases in response to hypoxia, making it a key regulator of erythroid progenitor proliferation. ESAs are crucial in correcting anemia, especially when the bone marrow response is not impaired by nutritional deficiencies or chronic diseases. Normally, there's an inverse relationship between hematocrit or hemoglobin levels and serum erythropoietin. Non-anemic individuals have low EPO, but in severe anemia, EPO levels rise exponentially. However, in chronic renal failure, this relationship is disrupted. Inflammatory states can also suppress EPO secretion, iron delivery, and progenitor proliferation due to cytokine activity. Understanding these dynamics is essential for effective anemia management. Erythropoietin stimulates erythroid proliferation and differentiation by binding to EPO receptors on red cell progenitors, activating the JAK-STAT pathway. This leads to increased red blood cell production, provided the bone marrow is healthy and not suppressed by nutritional deficiencies or disease. Recombinant human erythropoietin, produced in mammalian cells, mimics the effects of endogenous EPO and is widely used in clinical practice. Several EPO preparations exist, including epoetin alpha, beta, omega, and zeta. These differ mainly in carbohydrate modifications due to manufacturing processes. They are available for intravenous or subcutaneous administration. Epoetin alpha, for example, has a plasma half-life of 4-8 hours, but its effects on marrow progenitors last much longer. Notably, some athletes have misused epoetin alpha for blood doping to enhance performance. Thrombopoietin alpha is a modified, more heavily glycosylated form of erythropoietin with a 2 to 3-fold longer half-life than epoetin alpha. Methoxypolyethylene glycolepoetin beta is another long-lived recombinant product, administered at longer intervals every 2 weeks or monthly. In contrast, epoetin alpha is typically given 3 times a week and darbepoetin weekly. These options provide flexibility in anemia management, especially for chronic conditions. Recombinant EPO therapy, combined with adequate iron intake, is highly effective for several types of anemia, including those associated with chronic renal failure, chemotherapy, chronic inflammatory diseases, and surgeries with anticipated blood loss. The primary goal is to reduce the need for repetitive blood transfusions, improving patient outcomes and quality of life. During EPO therapy, patients may develop absolute or functional iron deficiency, so supplemental iron is recommended for those with low ferritin or transferrin saturation. Adverse effects include hypertension, especially in those with pre-existing uncontrolled hypertension, thrombotic complications, and potential aggravation of leukemia or other myeloid cancers. Monitoring and appropriate precautions are essential during therapy. Myeloid growth factors are glycoproteins that stimulate the proliferation, differentiation, and function of various myeloid cell types. Produced by fibroblasts, endothelial cells, macrophages, and T cells, these factors act at extremely low concentrations via cytokine receptors. The two main clinically used myeloid growth factors are GM-CSF and GCSF. each with distinct roles in blood cell production. Granulocyte macrophage colony stimulating factor, GM-CSF, is a multipotential growth factor that stimulates the proliferation and differentiation of several progenitor cells, including those for granulocytes and macrophages. It also enhances the function of neutrophils, monocytes, and eosinophils, aiding in infection and cancer defense. GM-CSF mobilizes hematopoietic stem cells from the bone marrow to the periphery, especially during inflammation or allergic responses. Recombinant human GM-CSF, known as sagromostim, is produced in yeast and primarily stimulates myelopoiesis. At lower doses, it mainly increases neutrophils, while higher doses can cause monocytosis and eosinophilia. Sagromostim is administered intravenously or subcutaneously, with a serum half-life of 2-7 hours, making it a valuable tool in managing neutropenia and supporting bone marrow recovery. Granulocyte colony stimulating factor, GCSF, is more specific than GM-CSF, acting mainly on neutrophils and their progenitors. It stimulates their proliferation and function, while also reducing inflammation by inhibiting certain cytokines. GCSF is especially effective in mobilizing hematopoietic stem cells into peripheral blood, a key advance in stem cell transplantation. Recombinant human GCSF, such as filgrastim, is produced in bacteria and primarily stimulates neutrophil production. It is eliminated by the kidneys, with a serum half-life of about 3.5 hours. Longer-acting forms like pegfilgrastim and lipefilgrastim allow for less frequent dosing, making them convenient for patients undergoing chemotherapy or stem cell mobilization. Myeloid growth factors are mainly used to shorten the duration of neutropenia and reduce infection risk in patients undergoing bone marrow or stem cell transplantation, or receiving intensive chemotherapy. They are also used to treat congenital or cyclic neutropenia, myelodysplasia, aplastic anemia, and AIDS-associated neutropenia. Their most important role in transplantation is mobilizing peripheral blood stem cells. GCSF is preferred over GM-CSF for peripheral blood stem cell mobilization due to its higher efficacy and lower toxicity. GCSF reduces episodes of febrile neutropenia, antibiotic requirements, infections, and hospital stays during chemotherapy. Neither GCSF nor GM-CSF stimulates red blood cell or platelet formation, so they are sometimes combined with other growth factors for pancytopenia treatment. GCSF and pegfilgrastim are generally better tolerated than GM-CSF. Common adverse effects include bone pain, which resolves after discontinuation, and hypersensitivity reactions in patients with allergies to bacterial proteins. GM-CSF, especially at higher doses, can cause bone pain, fever, malaise, arthralgias, myalgias, and capillary leak syndrome, leading to peripheral edema and effusions. Thrombopoietic or megakaryocyte growth factors are endogenous compounds that stimulate platelet production. Thrombopoietin, TPO, and interleukin-11, IL-11, are key regulators. Recombinant IL-11 was the first agent approved for thrombocytopenia treatment, while recombinant TPO analogues were discontinued due to the development of autoantibodies. Patients with thrombocytopenia are at high risk of bleeding, making these therapies vital. IL-11, produced by fibroblasts and stromal cells in the bone marrow, increases peripheral platelet counts. The recombinant form oprelvecin is used for secondary prevention of thrombocytopenia in patients receiving chemotherapy for non-myeloid cancers. Adverse effects include cardiovascular issues like dyspnea, anemia, transient arrhythmias, as well as headache, fatigue, dizziness, and hypokalemia. Thrombopoietin receptor agonists are small molecules that mimic TPO. Romiplastim and L-Thrombopoietic are approved for treating immune thrombocytopenia, ITP, disorder marked by low platelet counts due to immune-mediated destruction and impaired production. Symptoms include easy bruising, superficial and prolonged bleeding, and spontaneous bleeding from gums or nose. Traditional treatments focus on reducing platelet destruction. Romiplastim is a non-immunogenic peptide agonist of the thrombopoietin receptor, administered subcutaneously and eliminated by the reticuloendothelial system. Its half-life is inversely related to platelet count. L-Thrombopoietic, an orally active non-peptide agonist, is approved for chronic ITP and has a longer half-life, being metabolized and excreted mainly in the feces. Both drugs significantly increase platelet counts in most patients who have not responded to other treatments. Romiplastim's most common adverse effects include joint pain, dizziness, insomnia, extremity pain, abdominal pain, and muscle pain. Serious but less common effects are bone marrow fibrosis, hematologic malignancies, and thrombosis. L-Thrombopoietic can also cause bone marrow fibrosis, malignancy, thrombotic events, and hepatotoxicity. Careful monitoring is required during therapy. Anemia is a group of diseases characterized by decreased hemoglobin or red blood cell volume, resulting in reduced oxygen carrying capacity. According to the World Health Organization, anemia affects about 1.6 billion people worldwide. It is defined as hemoglobin less than 13 gdl in men and less than 12 gdl in women. Understanding the causes and management of anemia is crucial for effective patient care. Anemia occurs when the balance between red blood cell production and destruction is disturbed. Causes include blood loss, acute or chronic, impaired red cell formation due to deficiencies in iron, vitamin B12 or folic acid, bone marrow depression, erythropoietin deficiency, and increased destruction of red blood cells, hemolytic anemia. Identifying the underlying cause is key to choosing the right treatment. Acute anemia may present with symptoms like palpitations, angina, lightheadedness, and breathlessness due to decreased oxygen delivery or hypovolemia. Chronic anemia often leads to fatigue, weakness, headache, dyspnea on exertion, vertigo, sensitivity to cold, pallor, and loss of skin tone. With chronic bleeding, the body adapts, so faintness and lightheadedness are less common. Anemia can be classified based on red blood cell morphology. Microcytic hypochromic anemia, usually due to iron deficiency, macrocytic anemia, often from vitamin B12 or folic acid deficiency, and normocytic anemia, caused by recent blood loss, bone marrow failure, or chronic disease. This classification helps guide diagnostic and therapeutic decisions. Iron deficiency is the most common nutritional deficiency and the leading cause of anemia worldwide. Symptoms include pallor, fatigue, dizziness, and exertional dyspnea. Cardiovascular adaptations, such as tachycardia and increased cardiac output, can worsen underlying heart conditions. Addressing iron deficiency is a cornerstone of anemia management. Iron deficiency can result from inadequate intake, malabsorption such as after gastrectomy, blood loss, menstruation, peptic ulcer disease, or increased requirements, pregnancy, infancy, chronic kidney disease. Without enough iron, small pale erythrocytes form, leading to microcytic hypochromic anemia. Iron is the Earth's most abundant metal and a crucial nutrient for humans. It exists mainly as ferric oxide or hydroxide in the environment and is only biologically available when solubilized. Iron is vital for transport proteins, enzymes, and the regulation of cell growth and differentiation. Its two oxidation states, ferrous Fe2+, and ferric Fe3+, enable participation in essential metabolic reactions. Most of the body's iron, about 65%, is found in heme protein complexes like hemoglobin and myoglobin, which transport oxygen. For hemoglobin, oxygen binds directly to the iron atom in the Fe2+ state, stabilized by the protoporphyrin ring. The rest of the body's iron is stored as ferritin or hemosiderin, or found in enzymes and myoglobin. About 25% of body iron is stored as ferritin or hemosiderin, mainly in the liver, spleen, and bone. Myoglobin accounts for around 7%, with the rest in enzymes. Iron content varies by gender, with men typically having higher stores than women. This difference has clinical implications, especially in reproductive age women. Dietary iron comes in two forms: heme iron, found in animal products like meat and fish, and non-heme iron, found in plant foods such as legumes and leafy greens. Heme iron is absorbed more efficiently than non-heme iron. The average diet contains 10–20 mg of iron, but only about 5–10% is absorbed, mainly in the duodenum and proximal jejunum. Most dietary iron is in the ferric Fe3+ form and must be reduced to ferrous Fe2+ by stomach acid and ferroductase before absorption. Two transporters in intestinal mucosal cells handle iron. DMT1 carries Fe2+ into the cell, while ferroportin exports Fe3+ into the blood after oxidation. This process ensures efficient iron uptake and regulation. Several factors influence iron absorption. Body iron stores inversely related, type of iron consumed, and other foods eaten simultaneously. Meat and vitamin C enhance non-heme iron absorption, while phosphates, tannins, and calcium inhibit it. Women, especially those menstruating or pregnant, have higher iron requirements and absorption rates. When body iron stores are high, intestinal mucosal cells store iron as ferritin rather than transporting it into the bloodstream, preventing toxicity. This adaptation is crucial for maintaining iron homeostasis and avoiding overload, which can be harmful. Free inorganic iron is highly toxic, so it is transporting in plasma bound to transferrin, a protein that delivers iron to cells via specific receptors. Most transferrin-bound iron is used by bone marrow for hemoglobin synthesis, while smaller amounts are stored in the liver or used by muscles and other tissues for enzyme production. Iron is stored as ferritin in macrophages of the liver, spleen, and bone, as well as in liver cells. The release of iron from these stores is regulated by hepcidin, which controls ferroportin activity. Low hepcidin increases iron release, while inflammation raises hepcidin, reducing iron availability and contributing to anemia of chronic disease. The body conserves iron efficiently, with no active excretion mechanism. About 1 mg is lost daily through feces, exfoliated cells, and bile, with women losing slightly more due to menstruation. This conservation underscores the importance of regulating iron intake and absorption to prevent deficiency or overload. The main indication for iron therapy is the treatment or prevention of iron deficiency anemia, characterized by pale, small red blood cells and specific laboratory findings. Oral iron is usually effective, but parenteral iron is preferred in cases of poor absorption, intolerance, or high requirements, such as in chronic kidney disease patients on hemodialysis. Oral iron comes in two main types: ferrous and ferric salts. Ferrous salts are preferred due to better absorption and cost-effectiveness. Common forms include sulfate, fumarate, succinate, gluconate, and aspartate. The effective dose is based on elemental iron content, with about 200 mg per day divided into 3 doses for treating deficiency. Average effective dose for iron deficiency anemia is about 200 mg of elemental iron daily, divided into 3 doses. Recovery of hemoglobin depends on anemia severity, with severe cases taking a month or more. To replenish iron stores, treatment continues for 3–6 months, as absorption rates decrease after anemia correction. All oral iron preparations can cause dose-dependent gastrointestinal side effects, including nausea, discomfort, cramps, constipation, and diarrhea. Starting at a lower dose and gradually increasing can help minimize these effects. Black stools are common but harmless. Oral iron should be avoided in patients with peptic ulcers or inflammatory bowel disease. Several drugs can interfere with iron absorption. Antacids, H2 blockers, and proton pump inhibitors decrease absorption, while zinc competes for transporters. Tetracyclines and fluoroquinolones may have reduced absorption if taken with iron. Vitamin C enhances absorption, but may also increase side effects at high doses. Parenteral iron is used when oral therapy fails, is not tolerated, or absorption is impaired. It's also indicated for severe deficiency with chronic bleeding, non-compliance, or in chronic kidney disease patients on erythropoietin therapy. Parenteral iron ensures adequate iron supply for effective anemia management in these special situations.